Good afternoon, and welcome to our virtual program, Let's Sleep, Sleep Distractions and Adjusting to Change. We are very grateful to have Dr. Alkatip Smith, Dr. Nye, and Dr. Tam with us today. A little bit about our speakers. Dr. Alkatip Schmidt is a New Jersey native dedicated to providing high quality care for pediatric sleep medicine patients. After graduating from Emory University and the University of Virginia School of Medicine, she completed her general pediatrics and child neurology residencies at the University of Penn Medical Center Children's Hospital of Pittsburgh and her sleep medicine fellowship at the Children's Hospital of Philadelphia Hospital of the University of Pennsylvania. She received her Master's of Science in Translational Research from the Perelman School of Medicine at the University of Pennsylvania, studying sleep and autism spectrum disorder. Her clinical interests include sleep apnea, parasomnias such as sleep terrors and sleepwalking, insomnia, sleep difficulties, circadian rhythm disorders, daytime sleepiness, and restless leg syndrome. She is board certified in both sleep medicine and neurology with a special qualification in child neurology by the American Board of Psychiatry and Neurology. As a sleep pediatric medicine physician, she believes in blending both behavioral and medical approaches to provide the best possible care. Her goal is to help patients improve quality of life through the treatment of sleep disorders. She especially enjoys caring for patients with neurodevelopmental and other neuro-related disorders, such as autism spectrum disorder. Dr. Schmidt strives to partner with patients and families, share decision making, and provide exceptional care. Dr. Pakay Nye has been with Hackensack Meridian since 2004. He is an assistant professor at the Hackensack Meridian School of Medicine, where he lectures in pulmonary physiology. He is board certified in sleep medicine, pediatric pulmonology, and general pediatrics. Dr. Nye is a fellow member of the American Academy of Sleep Medicine. His areas of interest include sleep disordered breathing, medical and behavioral sleep disorders, and pediatric pulmonology disorders. Dr. Chi Tan is a pediatric pulmonologist and sleep medicine specialist at K. Hovnanian Children's Hospital. He received his medical degree from University of Calgary, Alberta, Canada, and completed his pediatric residency at Winthrop University Hospital in Mineola, New York. He completed both his pediatric pulmonary fellowship and sleep medicine fellowship at Cincinnati Children's Hospital Medical Center. Dr. Tan is board certified in sleep medicine, pediatric pulmonology, and general pediatrics. His clinical and research interests include sleep disordered breathing in children, asthma, and children with chronic respiratory failure. And at this time, I will turn it over to Dr. Tan to get started.
Thank you, Allison, for the great introduction. So we're going to start by just talking briefly about how we think sleep occurs. So sleep-wake cycle is thought to be determined by the interaction between what we call homeostatic sleep drive, or the process S, and our circadian rhythm, or we call the process C. So homeostatic sleep drive is directly determined by the duration of wakefulness. So the longer that we stay awake, the greater the pressure to put us to sleep. And the circadian rhythm, or the biologic clock in our body that kind of like determines when our cells rest and when our cells get active, is operate independently of the duration of wakefulness. So it's kind of fixed with usual dip in the evening. So when we have like the greatest sleep pressure at the end of the day, after a long day of being awake, and decrease in the alertic signal from our circadian rhythm, determined mostly by our melatonin secretion, as well as other neurotransmitters. That's how kind of like we feel sleepy and make us sleep. Next slide. So in terms of the circadian rhythm development, or when our biological clock develops, when we're born at term, the sleep-wake periods occur randomly. So that's why like the babies not really have like a fixed sleep schedule. They sleep and wake, and I mean basically they sleep and feed throughout the day. And then when they turn a month old, that's when our core body temperature starts to have a rhythm where the temperature will drops when we sleep at night and then increases towards the morning as we wake up. When they're about 3 months old, there are certain hormones that will start to cycle in a circadian rhythm. Examples like our melatonin and the cortisol. And between 4 to 6 months, as the circadian rhythm slowly matures, that's when you will notice that the babies around this time, they're starting to consolidate their sleep and they're more able to sleep through the night. Next slide, please. So a slide regarding the screen use and sleep health. Recently, National Sleep Foundation came out with a consensus statement after rigorous review on all the studies and evidence that look at screen use effects on sleep health. And they come up with these conclusions. Basically, in general, screen use does affect our sleep health among children and adolescents as well as adults. They conclude that the content of the screen use before sleep has a greater impact compared to just the light exposure itself. But if you do certain strategies, behavioral strategies, or interventions, such as like using blue light blocker or blocking glasses, things like that, it can help with the negative effects of like screen use on sleep health in general. Next slide, please. So how much sleep do kids need? The American Academy of Pediatrics recommend that teenagers need to get at least 8 hours of sleep. Grade schoolers between 6 to 12 years of age will need like at least 9 hours of sleep. Preschoolers will need at least 10 hours of sleep. Toddlers about 11 hours, and infants above 4 months old between 12 to 16 months of 16 hours of sleep, including nap time. There's a bedtime calculator if you're interested in sleepeducation.org, depending on the age group and what time they have to wake up. The website will kind of help you what their ideal bedtime will be. Next slide, please. So regarding naps, as I mentioned earlier, newborns typically sleep and wake throughout the day just to feed and sleep. And then as they get older, between 9 to 12 months of age, the general will take about like 2 naps a day, mostly during the late morning and early afternoon. And then as they get older, between 15 to 24 months of age, they'll have like a 1 long nap, mostly in the late morning. And most kids after 5 years of age, they no longer need naps. Next slide, please. More information about what is normal sleep for babies. Again, before 6 months of age, it can be normal for infants to have like irregular sleep patterns because their circadian rhythm has not matured totally. But they should start like sleeping through the night between 4 to 6 months of age. Next slide, please. So regarding like safe sleep practices for infants, during this age, it's most important to practice like good sleep practices to prevent sudden infant death syndrome or sudden unexpected infant death syndrome. So the Academy of Pediatrics recommend babies should sleep alone in the crib or bassinet in their parents' room up to 12 months of age. They need to sleep on a firm surface. They shouldn't sleep on like sofas or armchairs, and they need to sleep in an empty crib without any like soft toys around them, blankets, things like that, that can potentially be a suffocation hazard. Bumper pads in the crib are not recommended. And then they should like sleep in sleepwear there's like loose and avoid like loose blankets in the crib again, avoid head coverings such as hats to prevent overheating. And do not use like sitting with devices such as like car seats or strollers for their routine sleep. If they fall asleep, then you should try to move them to their crib or bassinet as soon as you can. Pacifiers may be used during sleep, and most importantly, avoid like secondhand smoke or nicotine exposure because that increases the risk of sudden infant death syndrome. Next slide, please.
Um, this is now moving over a little bit older. So we're looking at 1 to 2 years old. And this is just a sleep pyramid I created just to help us all visualize what's needed to help children get the best sleep. And if you start at the bottom with step 1, this is again for 1 to 2 year olds, you want to think about good daytime habits with children being active every day, trying not to have them take too late of naps. Obviously, at 1 to 2 years old, they will be taking naps, but you want them to be up by 4 p.m. or so that it doesn't decrease their sleep pressure so much that they're not ready to fall asleep a little later. You want your children to eat regular meals. They're obviously very young, so no caffeine. And then you move on to a good sleep environment, step 2. So when you're doing a bedtime routine at night, you want to move toward the bedroom. So you don't want to bring them to their room, change them, then go back downstairs, then come back. You want to just move all in the direction of the bedroom, so you end there. The room should be cool, dark, and quiet. No electronics, no screens on or TVs on in the room. And then you would only want to use the crib for sleep. And so that would be trying not to do a lot of playing in the crib because you want to give their brain the right signals that the crib is for sleeping, not for playing. Then step 3 is looking at good sleep habits. So relaxing before bed, not doing something too stimulating. Put your child to bed drowsy but awake. It can be very disconcerting if your child falls asleep in one spot and then during the night they wake up and they're somewhere else because you've moved them into the crib and then they're going to be awake and may get upset. You want to try to have consistent sleep and wake times. And then for this age group, the goal is 11 to 14 hours, as Dr. Tan mentioned. This is a similar pyramid for 3 to 5 year olds. I'm not going to go over everything again, but the take home point is it's similar to the 1 to 2 year olds. It's just that the total sleep time for this age group is 10 to 13 hours. And this includes naps. Other tips on helping your children get the best sleep. You want to, as we talked about, do a consistent wake and bedtime. You may want to use a nightlight or table lamp that turns on to indicate it's the time to get up because children that are preschool age or younger, they don't know the concept of time. So using cues can help them. You want to do a consistent age appropriate nap time every day. Like we talked about, no electronics in the bedroom, a technology curfew so that, again, younger children especially really shouldn't be doing too many screens, but avoiding it 2 hours before bedtime. Encourage activity and exercise during the daytime, but you don't want to have kids doing a lot of exercise 2 to 3 hours before bedtime because then it can be hard to wind down. You want to avoid large meals before bedtime, eat a light, healthy snack if hungry before bed. And this slide, does include sort of older school-age children as well. And then you also want to remove caffeine containing foods or liquids from your child's diet. And that could be tea, soda, coffee, energy drinks, chocolate, all that stuff. It all contains caffeine and that can really affect sleep. This is the pyramid I made for 6 to 13 year olds. The biggest change is that if you look at good daytime habits, kids at this age really shouldn't be napping. So you want to try to avoid naps after school because again, they're not going to have enough time to build up enough pressure to sleep. And if they are needing naps, then it seems like, they may not be getting enough sleep at night. So then you want to look at what's happening at night and why the child needs a nap after school. It's again, the good sleep environment is very similar. At this age, also, you want to emphasize only using the bed for sleep. So having them not do screen time in bed or playing in their bed. And then for good sleep habits, once they wake up in the morning, it's helpful really at any age for them to get bright light. So you want to give those signals to your brain, like bright light in the morning, darkness or, dim lights in the evening. And for this age group, the goal is 9 to 11 hours. For teenagers, it can be more challenging with the sleep schedules because in some adolescents, their circadian clock, so that clock in their brain shifts a little later. And so their bodies are just not ready for sleep until a little later than when they were younger. And that also means their bodies want to wake up later, and there can be a conflict with the school start time. So it can be a little more challenging in this age group. But again, you want to try your best to keep consistent bedtime and wake times, especially between weekdays and weekends. You don't want the weekends to be so different than the weekdays, because then it's really hard to flip back and forth. Teens, again, a lot of them have their phones, so you could use an app or a timer as a reminder when to start getting ready for bed. Same thing with electronics, turn those off ideally 2 hours before bedtime. I'm trying to adjust the blue light emitted, so you can use filters. The filters don't mean you can just stay on electronics right up until bed, but at least it helps try to decrease some of that disruption from the light. Same thing, use bed only for sleeping. A lot of teens like to do their homework in bed, so you want to encourage them to not do that. And no video games in bed or anything like that. Try to have them wind down 30 minutes before bed. So winding down could be, some examples are putting on your pajamas, maybe showering, brushing teeth, trying to read a book or a magazine or listen to quiet music. So trying not to be on the phone scrolling and on social media, because it's just very stimulating. Plus you have the screen time. Another thing that can be helpful is to have your teens plan for the morning. So picking up their clothes for the next day, getting things ready for their backpack so they're not scrambling in the morning. Again, with the environment, keeping the bedroom dark, quiet, and cool. Go out in the sun in the morning. Try not to have sunglasses when you first are getting out of the house, because again, you want all that bright light to wake you up and help your circadian rhythm. And then in this age group as well, teens should be active, so trying to get exercise, but not doing it 2 to 3 hours before bed. Same with naps. You want to try to avoid naps, but especially not in the afternoon or evening, because it's going to be hard to fall asleep. If a teenager really has to do a nap, trying to do it earlier if possible, and only 20 to 30 minutes, just a quick nap, not sleeping for hours. And then you want to avoid large meals before bedtime, avoid caffeine. If there is caffeine, really you shouldn't have it after lunchtime, because it stays in your system. So you don't want to have any of it in the afternoon or evening. And then with teenagers, they are driving for many of them. So you want to make sure they're not driving when they're sleepy. They know that, if they're tired, they really shouldn't be driving, should get a ride. This is the sleep pyramid for teenagers. It's really just visualizing everything I just talked about. And the goal for teenagers is to sleep at least 8 to 10 hours. As far as melatonin, I know many families have questions about melatonin. It's just, all over the place. You see it everywhere. So when we think about medications or supplements for sleep, you always want to try behavioral interventions first. So there's really not a magic pill for sleep. And a lot of times what happens is that if there are sort of behaviors that discourage sleep, even if you had the best medicine in the world or the best supplement, it's not going to help because, there are sort of these other things getting in the way. So you always want to sort of take a step back, look at the sleep, look at, the environment, the sleep routine, sleep habits, all the things we just talked about before thinking about supplements or medications. Melatonin is very readily available. It's over the counter. It comes in liquid, gummy, chewables, tablets, all the different things. The thing with being a supplement is that it's not regulated really. And so, they've done studies where they find that, say, a company says there's 3 milligrams of melatonin. Well, that may not be true. It could be that they're actually 10, or maybe there's only 1, or maybe there's some other things, other supplements within the melatonin that aren't on the label. So it can get a little tricky. There is something called USP. It's this organization that tries to verify that what's in the supplement is what the company says is in there. So there is a USP verified mark. It gets a little trickier for some things because they don't I don't know if they have gummies that they've sort of verified, but if you look on their website, you'll see some common brands that they, seem to say are good. So you can at least get a sense of, some brands to stick with. The other thing with melatonin is that usage has been increasing, and that's also led to a lot of accidental ingestions. And melatonin is not entirely benign or harmless, and so you want to treat it like a medicine and keep it out of the reach of children, and only use the smallest amount possible. The other thing about melatonin is that timing helps. So for children, if you're trying to help them fall asleep, it's 30 to 60 minutes before bed. If it's a teenager and they have a very delayed sleep schedule, in clinic, we sometimes will use tiny, tiny doses of melatonin, and then we'll do it a couple hours before bed to try to shift their schedule earlier. I mean, for kids, you really, you really want to start low, like a half a milligram, 1 milligram. I mean, really for little kids, probably not going higher than 3 milligrams or so. Sometimes we go up to 5 or 6 milligrams, but, really trying to stay away from, as best as you can, sort of that adult dosing where, they're selling 10 milligram tablets or pills or gummies. There's, limited evidence for effectiveness in improving sleep in typically just developing children and then those with neurodevelopmental disorders, ADHD, autism, epilepsy. I will say, children, for instance, with ADHD or autism, we know that they have an increased risk of sleep difficulties. And so in these children, we do use melatonin more commonly because, we know that there's often an issue and it can be very beneficial. But like I said, in general, I would just encourage you to, try to see if there are other things you can address before sort of going towards melatonin. But again, some kids do need it. Um, Overall, the side effects are not huge. We don't know about the long-term side effects. Sometimes you can get drowsiness, headaches, that sort of thing from taking it. There's a question of whether or not it affects sort of puberty, though there have been some, recent study that said it was okay. But again, everything, it's still a supplement. And so you just want to be mindful when you use it.
Hi, everyone. This is Dr. Nye speaking. I'd like to focus on a couple of sleep hygiene issues that my colleagues already touched upon. And you see here children with their electronic devices at bedtime. Of course, I'm guilty as charged too with my phone, particularly when it's work related. But remember, many of us, depending on our age, didn't have these electronics growing up. And in the previous slide, Dr. Smith just addressed melatonin and the use of oral melatonin, but you should know that melatonin is actually already produced by your body by a gland called the pineal gland. And typically, your body starts to release melatonin about 2 hours before your anticipated bedtime. And it's not a sedative, but melatonin's a hormone that, in a sense, sets the stage for sleep. But we know that the electronic devices emit light, particularly a blue wavelength of light, and it's this that suppresses and delays your body's own melatonin production. And as you see on the right, that blue light is the biggest inhibitor of the melatonin surge. So these devices are often taken to bed, and you have this blue light, and not to mention the content of what's being watched, and it's both serving to keep you stimulated and less likely to fall asleep. So you're missing your body's own cue, the melatonin, its very own signal, which is trying to set the stage for sleep. And yes, I know some of these devices have either built-in or external filters blocking the blue light, but they're probably not perfect by any means. So you can imagine how children and us adults are having increasing difficulty falling asleep, but again, being in denial about the role of electronics. I try to tell my patients to be off electronics for at least an hour or maybe two before they want to fall asleep. I know it's easier said than done. So especially with my teenagers, I would also settle for 20 minutes and build up from there. Next slide, please. Some words about caffeine. And you may not think of it this way, but caffeine is indeed a drug and the world's most popular drug, no less. It can have its stimulating effect take place by 15 minutes after you drink it, and it has that half-life of about 5 to 6 hours, which means it can stay in your system for a while. As a general rule, as Dr. Smith said, you probably want to have your last caffeinated beverage around mid-afternoon, but definitely by 3 to 4 hours before your anticipated bedtime. An 8-ounce cup of coffee may have about 100 to 120 milligrams of caffeine. So one of those supersized varieties can take you up even higher. Most people can tolerate about 400 milligrams of caffeine per day, or about 3 cups, but that's for adults. Children, even teenagers, should be limited to no more than 100 milligrams per day. But we have kids using some of these energy drinks with a whole lot of caffeine that may be unaware of. So it's in Red Bull and Monster drinks, and more recently in these Celsius drinks, where there can be 200 to 300 milligrams of caffeine per can. Next slide, please. So I want to spend some time discussing something that will be occurring next month, specifically on the second weekend of March, which is that transition from daylight standard time to daylight saving time. And I don't mean to be a stickler about spelling or word choice, but the proper way to refer to this is daylight saving time, so no S at the end. So daylight saving was conceived as a way to make better use of daylight, to synchronize the daytime activities with natural daylight hours. So in the spring, you're basically moving an hour of sunlight from the early morning to the evening. And then in the autumn, we fall back. We move that hour of sunlight from the evening to the early morning. But it's these time shifts that can potentially be disruptive to the bedtime and nap routines for children, especially our younger children. Um, and there are quite a few presumptions about daylight saving time and how it came to be. Some credit the concept of daylight saving time to Benjamin Franklin, whose proverbs included "early to bed, early to rise makes a man healthy, wealthy, and wise." And there are writings from Franklin when he lived in France, where he noted that the French would get up earlier and go to bed earlier in order to save on candle consumption. Next is the concept of time zones, which is something we take for granted now, but there was a time when each city or town could dictate their own local times, where it could be like, let's say, 105 at Hackensack, or 115 at Edison, or 120 at Neptune City. And you might imagine this caused horrible timing and scheduling problems for businesses such as railroads, where there needed to be a standardization of time in order to function properly. So in 1883, a coalition of businessmen and scientists decided on the time zones that we live by today, meaning the Eastern, Central, Mountain, and Pacific time zones. Then during World War I, Germany was the first country to implement daylight saving time, and they implemented it to save on coal and energy costs. Soon, many other European countries followed suit, and by 1918, our U.S. federal government took oversight of the time zones, as well as officially adopting daylight saving time. Next slide, please. So many countries around the world do observe daylight saving time, about 70 nations, but the exact calendar dates that they adjust their clocks may vary depending on the country. And in the Northern Hemisphere, much of North America and Europe observe daylight saving time. As for the Southern Hemisphere, remember, their daylight saving time period gets observed during their summer, which is actually winter in the Northern Hemisphere. Back in the US, most states observed daylight saving time except for Hawaii and most of Arizona. The territories of Puerto Rico, US Virgin Islands, and American Samoa have also opted out of daylight saving time. Next slide, please. And in 1966, the US passed the Uniform Time Act, which standardized daylight saving time across the country and determined that 2 a.m. was the designated time to shift the clock. So the main thing in the spring, we come off standard time by springing ahead with the clocks moving forward 1 hour to get to daylight saving time. Then in the fall, the clocks are moved back 1 hour. We fall back during that first week of November. And this takes us off daylight saving time and returns us to so-called standard time. So right now we're still in standard time until next March. And again, we've all been made aware to do this at 2 a.m. However, most people just change their clocks the night before or the next morning. And many of our electronics or computerized clocks will automatically make the change for us. For as long as I can remember, people have been discussing whether we still need daylight saving time anymore, especially since the energy saving aspects don't really apply in this day and age. And according to many polls, most of us in the general public, about 70% of us, don't like this twice a year shifting. So what about Congress? It turns out that back in 2022, the Senate unanimously passed legislation doing away with the twice yearly time changes. But hold your horses, because the House of Representatives has not been able to come to a consensus to pass the bill. Next slide, please. So we'll look at how daylight saving time might affect us and our children. Now that we're on standard time, this means shorter amounts of daylight in the afternoon and evening. And that extra hour of darkness can be difficult for many of us, especially for those who might be prone to something known as seasonal affective disorder or even outright depressive episodes. And our professional sleep academy cites evidence that when you're shifting in or out of daylight saving time and disrupting the body's natural clock, that could lead to an increased risk of stroke and cardiovascular events. And it can also lead to more traffic accidents, particularly in that week following the time change. And for some, there might also be a reduction in cognitive and intellectual performance. Now, with children, especially the younger children, they are often creatures of habit. So their sleep wake schedules are often self reinforcing, meaning the more regular, consistently regular their schedules are, the more likely they are to stay in sync. So their body clocks have become locked into their routines. But now, twice a year, families who have worked so hard to get their children on a regular sleeping schedule, they're now faced with this challenge, as in the 1 hour spring ahead next month and the 1 hour fallback in autumn. So 1 hour may not seem like much for some, but we see that even this modest time shift can throw bedtime into chaos. Next slide, please. There are some strategies that might help to ease that abrupt change for children. So on March 9th, don't just move the clock forward an hour and expect your child to get right in sync. To help adjust, you may want to gradually shift your child's bedtime in preparation for daylight saving time. So if your child typically goes to bed at 8 p.m., then about 3 days before the time change, so let's say that Thursday before, put them to bed at 7:45 p.m. Then it should be a 7:30 bedtime on Friday, followed by 7:15 bedtime on Saturday. And then this time change of the spring ahead will take place. And then on Sunday night, have your child go to sleep at the physiologic 7 p.m. time, which is now 8 p.m. since we've sprung ahead. And during this stepwise process, it would also help to wake them up a little earlier using those same 15-minute intervals. And doing this step by step can make this less of a shock to the system. And getting exposed to morning sunlight is also important for regulating that sleep wake schedule. With sunlight, your cortisol levels increase, that gives you energy, and your brain stops producing melatonin. So again, morning light is basically one of the strongest ways your body clock resets itself to the outside world. Next slide. So now you've heard us talk about sleep duration expectations, sleep hygiene measures across the different age groups, and we just looked at how daylight saving time can throw a wrench in these sleep routines. And now we'll explore when it might be warranted to see one of us to see a pediatric sleep medicine specialist. Next slide. So you might ask, how concerned should I be about my child's sleep? And pictured here is my son an unbelievable 17 years ago, and I caught him yawning at just the right time. And so this is an example of being a negative role model, meaning what not to do. As you can see, my infant son about to fall asleep on the couch, not his crib, with a TV remote and a can of cola nearby. And of course, this photo is not meant to make light of sleep problems. And the fact that you're registered for this webinar means you consider sleep a priority, and you're looking for ways to optimize your sleep and your family's sleep. However, as with many things, you're not exactly in your child's shoes. So at our sleep clinics, we have to tease out what the parent is perceiving versus what the child is living through. And often it turns out that the child, him or herself, may not be likely to complain about being sleepy. Even older children may not know better, that their sleep could be suboptimal. So instead, we may have parental complaints concerning their child, as listed here, with observations of sleepiness, poor school performance, hyperactivity, behavioral mood changes, and even driving impairment for the older teens. And we also get referrals from developmental pediatricians, neurologists, school counselors, psychiatrists, and psychologists asking us to look at the child's sleep, particularly when diagnoses of ADHD or autism are being considered. Because if a child's getting bad nights of sleep repetitively, then the healthcare provider would want to know about that before just prescribing medication or therapy. Next slide, please. And when your child is at the pediatrician's office, it's not just sleep, of course, that's the sole focus of a well child visit. But for practitioners that have the time and inclination, I've encouraged the use of this BEARS instrument, which is a short questionnaire devised to be a quick review of sleep-related issues. So B is for bedtime problems. Does your child have any problems going to bed? Problems such as bedtime resistance or stalling tactics or nighttime fears. E is for excessive daytime sleepiness. So does your child seem overly tired or sleepy a lot during the day? Is the child sleepy at inappropriate times in the wrong settings, such as at school? Has there been difficulty waking up in the morning? Or it can be that a previously alert child has now changed, is now noticeably sleepy at times compared to when he or she was awake in previous months or years. A for awakenings during the night. Does your child wake up a lot at night? Is there difficulty falling back asleep? Um, are the awakenings spontaneous and gradual, or perhaps the more abrupt awakenings of sleep terrors, or even sleepwalking, or even nightmares? Um, R stands for regularity and duration of sleep. So does your child have a regular bedtime and wake up time? And does it vary by more than an hour on weekends? What's often overlooked is the benefit of a regular, consistently regular sleep wake schedule and how that is self reinforcing. And for duration, we saw one of the earlier slides outlining the recommended durations of sleep per night, which helps the parent and the family manage expectations about how much their child should be sleeping. And S stands for snoring or sleep disorder breathing. And last but not least, if there's one important question I hope it gets asked by the pediatrician, it would be whether the child snores. So does your child snore or have difficulty breathing at night? Aside from the snoring, other noises and symptoms I ask about are gasping or snorting, breathing with your mouth open, throat clearing noises, overall restless sleep, nighttime sweating, and even bedwetting. And that's because these can be signs of potential obstructive sleep apnea. And sleep apnea is a medical condition that's more frequent than you might think, affecting 2 to 4% of the pediatric population. So I tell my patients and their families when we are looking at the sleep issues, I often have to see how much of the problem is possibly medical versus how much of it is behavioral. Next slide, please. So if there's a suspicion of a medical sleep disorder, especially a breathing related one, then the child and parent may be invited for an in laboratory overnight sleep study. And the technical name for a sleep study is polysomnography, meaning many physiological factors are monitored, while a sleep lab technologist stays in attendance overnight as well. And we aim for a family friendly experience in a hotel style environment. Of course, in a hotel, no one's putting electrodes and sensors on your child. And remember, it's not a hospital admission, but it's still considered an outpatient procedure. And remember, in this day and age, these rooms are deep cleaned after each overnight usage. There's often a full-sized bed for the child or a crib for the younger ones, and a parent sleeps in a pull-out sleeper chair within the same room. The child is encouraged to sleep on their own, but if sleep is not occurring, then sometimes we have to relent and allow co-sleeping. Otherwise, it would be a wasted night entirely. Next slide, please. And this picture shows the standard types of monitoring used in sleep labs. And none of these attachments are painful or break the skin. And at the top, you have these sensors on the head known as the EEG, where the recording of the brainwave patterns tells us whether your child is in light sleep, deep sleep, or dream sleep. Probably the most invasive part of the study is an attachment that's placed on the upper lip and directed towards the nostrils with what is called a cannula. And this cannula is not giving oxygen, which some people might be familiar with, but it's actually a sensor that measures how well the air is moving in or out from either your nose or mouth. So this is important in detecting regular breathing or shallow breathing or actual pauses in breathing, which is what's known as an apnea. And on one of your child's fingers or toes, a device known as an oximeter measures the child's oxygen level throughout the night. So if a child loses oxygen during the night, that can also be a cause of disruptive sleep and awakenings. And of course, when you as a parent sees this setup, you might think, how is my child ever going to sleep with all this on? So we don't expect your child to sleep like they do at home, but really a large majority of children are eventually able to sleep, and at least for like a minimum 6 hours. And it's this sleep study that is sometimes necessary to exclude possible medical sleep issues. So if your child is not in any medical danger when they sleep, as determined by a sleep study, that allows us to focus more on the behavioral and sleep hygiene issues. Next slide.
So that is the end of our talk, but what I wanted to do was just add a couple of slides that pertain to the questions you all sent in advance. A lot of them had to do with sleep training or just help with different bedtime or nighttime struggles. So I wanted to talk about gradually moving parents or caregivers out of the room when it's bedtime, because a lot of children, do have that association with an adult, a parent, a loved one when they fall asleep. And the way you fall asleep is how you stay asleep. So if you fall asleep with a parent there, then when a child just naturally has a natural awakening during the night, their brain says, "Oh, I need that parent to fall back asleep." And then they're coming to your room looking for you or crying out for you because, again, their brain has made that association. So one method is to start with parental presence, meaning the parent sits near the bed. And it might be you're on the bed, you're next to the bed, wherever it is, wherever your child is at right now. And you try to decrease the interactions as much as you can, and you stay there for a couple nights, and then you move a little further away from the bed. And then, do the same thing. Do that for a couple nights, then move a little further until you're out the door and into the hallway. So that's one method. Another method would be doing an increased duration of parental absence. So you first have to understand about how long it takes your child to fall asleep. So you can just keep track of that with the sleep diary for a week. And then you stay with the child half the time it typically takes to fall asleep. So if they take 30 minutes, you stay with them for half, so 15 minutes. And then you take a short break, like 1 minute. Maybe you say, I'm going to the bathroom, I have to check the laundry, whatever it is. Then the parent returns, gives verbal praise or maybe a little reward for staying in bed. And then you stay until the child falls asleep. And then each night the break gets a little longer. So you could add a minute, a couple minutes, depends on the child. And you do that until your child's falling asleep on their own. And there are, many, many different variations of this, but I'm just going to go over a few. Another common question from parents is, or issue would be bedtime problems. So this would be, children resisting going to bed or getting up, saying one more thing. So you always want to start with a good bedtime routine. You want to set a foundation. And if needed, you can do positive reinforcement for completing each step of the bedtime routine. You can do a visual bedtime chart where you have all the steps of the bedtime routine. There's actually just a free one online through the Autism Treatment Network, which I use for any child because they have the pictures already created and you just have to print it out and cut them out and put them on a piece of paper. So you give all this praise for completing the steps of the bedtime routine. And then you can do, once the child's in bed, the parent returns for good nights at scheduled intervals, like every 5 minutes, for instance, every 2 minutes, whatever works. And then if the child's still in bed, you give verbal praise, and you can also receive a token, and then you gradually increase the time between checks. And then once a certain amount of tokens are earned, then the child can trade them in for a prize. And then with time, you gradually increase the number of tokens needed to earn the prize. So that's one method. Another method would be using a sleep fairy. So, if the child falls asleep every night, for instance, on their own, then you set an amount of time and then you leave a little prize under their pillow in the morning. And you could do this more consistently and then try to space out the amount of nights that, they need to do this to earn a sleep fairy visit. Another one is the bedtime pass, which I use a lot. It's bedtime or nighttime pass. So again, actually Autism Treatment Network also has little bedtime passes on their website, but really you just need an index card with some kind of fun picture on it, and you give the child a pass, and they can also help draw one, whatever you want to do. And so when the child goes to bed, you give them their bedtime pass. And if they call out for their parent or get out of bed or, say one more thing, one more drink, one more anything, then they have to hand in their pass. It's kind of like a ticket. But if they don't hand it in and they wake up in the morning and still have their pass, then they trade it in for a reward. You can also use this for middle of the night awakenings. If the child's able to stay in their bed and not come to a parent's bed, then and they still have their pass in the morning, they get a little reward. So that can help. Other behavioral interventions that can help. One of them is the good morning light. We talked about earlier in the talk how younger children don't have a concept of time. And so sometimes it's helpful to do a good morning light. The child has to be at least 16 to 18 months old because they still have to have some comprehension of time. And what you do is you determine the average bedtime and wake up time. Again, you may need to just keep track of that. And then you do a night light with a timer in their room that turns on or that changes color 30 minutes before bedtime to indicate it's now time for bed. And then if children wake up during the night, you point out that the light's still on, so it's still sleeping time. And then you have the light turn off at the earliest time the child can wake up for the day. And when the light does turn off, you should go into the room, make a big deal, like, okay, it's morning, let the child know that now the light's off, so now we can start the day. And once the children have made this association, you can move their wake time 15 minutes later, if desired, every 5 to 7 nights to try to get the sleep schedule you're aiming for.
Thank you so much, doctors. There are a couple questions that were submitted through the Q&A. The first one is there caffeine in seltzer water?
Seltzer water? I don't believe so.
Yeah, I don't think there are, unless they intentionally, advertise it, there's usually not any caffeine in seltzer water.
Great, thank you. The next question is, do you recommend sound machines like a Hatch for toddlers? Who wants to take that one?
I can take it. So it depends. So with sound machines, well, the first thing, the American Academy of Pediatrics recently talked about safety with sound machines. So you want to make sure they're set at the lowest possible volume. They're as far away from the crib or the bed as possible. So you just don't want, your child exposed to loud noises all night. So that's step one. And then the other thing can be, if your child is really sensitive to external noises or sounds, it could be helpful to do a sound machine. Just as I mentioned, the way you fall asleep is how you stay asleep. So if you're doing a sound machine, then it probably has to go the whole night, because if it turns off during the night, then when your child has a natural awakening, they'll say, their brain will say, where's the sound machine? So, but if you need it again to sort of disguise sounds or kind of provide that soothing, then that could be an option as long as it's not too loud and it's far away from them. And then, on the flip side would be if your child, doesn't need it, I wouldn't just add it just to add it, because, then again, it is something then you would probably need to do nightly and keep going all night. So it really just depends on what your child needs.
Thank you. The next question is, any tips on sleeping while traveling with toddlers and babies?
I'll take this one. It's kind of similar to what I talked about with the change in to daylight saving time. So depending on the distance of travel, of course, you may have to cross 2 or 3 time zones, or maybe even longer for international travel. So if it's at all possible, you might want to prepare by having the younger child shift their nap routine a little bit earlier or later, depending on which direction in the world or country that you're going to. And it's not the easiest things because you're not at in your home environment now, so you have to find a place that's ideally a cool, dark, a quiet environment. But that's not always going to be the place when you're traveling, especially you have to stay in hotels or at relatives' houses. So I don't think there's an easy answer on this. But like I said, as far as the switching time zones, you may want to get a little ahead of this of that by shifting time bedtime routines even before you travel.
There's like applications available like Time Shifter. If you look in the App Store, that can help you guide on the amount of hours that you need to shift depending on where you travel.
Thank you. The next question, it's a two-part question. What constitutes sleep research? And do you believe in the new wave Zen tourism with less activities and more sleeping groups?
What constitutes sleep research? I guess sleep research happens for different age groups. In kids, they usually track your sleep either by using like a actigraphy watch that track movements, as well as like sleep diaries from report from parents. And then they correlate with outcomes such as different cognitive skills to look at their cognitive function and their reaction time and things like that. So that's how they usually perform sleep research in children.
Okay. Any feedback on, do you believe in the new wave of Zen tourism with less activities and more sleeping groups?
I'm not familiar with like those for children per se, but they may have like programs for adults to help them reduce stress and relax, so that they're able to, get away from the hustle and bustle of the day and help them relax and chill more, and that will help with sleep.
Okay, thank you. The next question is, what temperature or temperature range is recommended for a cool room for sleeping?
I've usually seen anywhere from like 68 to 72 degrees. So there's not a set temperature, but then we have some issues with different rooms having different zones. So even though you set the thermostat at a certain range, it may not make that temperature. So you do have to measure the temperature in each respective room. But we go with that 68 to 72 degree range.
All right, thank you very much. At this time, we don't have any other questions, so we will wrap it up. And I just want to thank Dr. Schmidt, Dr. Tan, and Dr. Nye. This was very helpful and informative. And I thank you all for taking the time to join us today. Please watch your email for an evaluation of the program. We hope that you'll take time to fill it out. We'd love to hear from you. And also let us know what other topics of interest. The link to the recording of the webinar will be included as well. It'll also be posted on our website on hackensackmeridianhealth.org/kids. And then we have a couple other parent forum webinars coming up that we hope you'll join us for. On March 27th is on headaches and seizures. And May 29th is how to help your child excel in sports, your child's athlete toolkit. So again, you can visit our website to find out more information about those programs and to register. So again, thank you all for participating, and we hope you enjoy your day and hope you all get a better night's sleep. Take care.